Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Meghan Phillipp, and I am the Executive Director of HC3. Over the past 4+ years, HC3 has evolved into a mission-driven platform convening Chicago's healthcare leaders and stakeholders to address issues and barriers that our industry faces. We proactively seek uncommon alignment to improve Chicago's healthcare ecosystem through the lens of our 3 pillars: addressing health and social inequities, driving economic development, and fostering system transformation. I am so proud to announce the release of our 4th annual State of Chicago Healthcare Report, which outlines local trends on policy, capital formation, innovation, and health equity. Now, I cannot take credit for the creation of this document alone, and would like to take this moment to recognize and share my gratitude to the colleagues from Third Horizon Strategies team and others that have contributed to this year's report. Caleb Allen, Hiba Al-Sheikh, Jessica Casebolt, Jordana Choquer, Ashley DeGarmo, Peter Freeman, and David Smith. Additionally, we had a guest author this year that supported a new section of the paper, Racism, Unrest, and Equity, which was written by Fernando de Mayo, who will be joining us for today's discussion. The goal for today's forum is to review our findings and unpack some of our observations of 2020 and to offer some predictions for what we can expect or are already starting to see in 2021. Before we get started, I just have a few housekeeping items. This afternoon's discussion is being recorded and will be shared on our website, hc3.health, in the days to come. As we hear from today's experts, if you have a question, please use the Q&A function, which we will be seen directly by our panelists, and our moderator will do his very best to address them during the audience Q&A portion of today's program. To kick things off, we have some remarks from one of our co-founders, Stephen Collens, the CEO of Matter. Over to you, Stephen.
Thanks so much, Meghan. As Meghan mentioned, I'm the CEO of Matter. We're a healthcare technology incubator and an innovation hub, and a co-founder of the Healthcare Council of Chicago. It's been an extraordinary year. We've experienced so many things that none of us really imagined we'd be confronting. We're closing in on 500,000 deaths from coronavirus. We saw racial unrest that, when combined with the coronavirus, really laid bare the reality of health inequities that are one of the defining features of our healthcare system. We impeached the president twice. I think it's safe to say this last year has been truly, truly awful. That said, if there are any silver linings to it, it would be that healthcare innovation, which has always been important to some of us, is now very obviously and evidently critical to all of us. We learned that even the most complicated and bureaucratic health systems can make decisions quickly when need be. And we've seen that health inequality is not something that anyone can deny anymore as a reality of our healthcare system. So at this moment in time, despite new coronavirus variants, despite challenges with the vaccine rollout, I am feeling very optimistic that we're on track for a better year in 2021, and that Illinois can play a leading role in charting a more positive future for all of us. We formed the Healthcare Council of Chicago as a way to bring the healthcare community in the Chicagoland area together to support economic development, support healthcare transformation, and help address health disparities. One of the key things that we do each year is produce this report on the state of the healthcare industry in Chicago. I may be a little biased, but I think this year's report is the best we've done yet. And if you haven't already, I encourage you to give it a read through. You'll see that we started work in our core areas. We advanced work in our core areas in 2020, and stay tuned for what's to come this year as we continue our efforts. Matter founded HC3 together with David Smith, who for his day job founded and leads Third Horizon Strategies. David is a transplant to Chicago, but his passion for the city and for the city's healthcare ecosystem puts many native-born Chicagoans to shame. He is a brilliant strategic thinker who knows his way around the payer and provider landscape as well as anyone I've ever met, and has been a great collaborator with us in building and shaping and leading HC3. So David is going to share more about the paper and then engage in a discussion with our terrific group of panelists. So David, I will turn it over to you.
Stephen, thank you. For everybody's awareness, we are recording the session and we'll make it available on the HC3 website when we're done, which is good because we can memorialize the really nice things Stephen Collens just said about me. Because I don't think I've ever heard such nice things come out of his mouth in my direction. Stephen, thank you so much for your partnership and leadership in all of these areas here in the city. I want to take just a few minutes to summarize the report while also teeing up the environment, and then have the chance to bring my colleagues in to go just a little bit deeper. If you haven't read the report, as Stephen said, I encourage you to do it. It's not going to read like a Game of Thrones novel, but it's also not going to read like a white paper. I think you'll find a really nice cross-sectional view of what's going on in the city and some things that might challenge your thinking or raise opportunities in your own mind about how you can be involved or drive or position the business you participate in or lead to be opportunistic about the environment we're walking into. I also want to just reiterate Stephen's notion that I think collectively all 7 billion of us would look at 2020 as a difficult year. And 2021 has followed suit, continuing to pose difficult social, political, economic challenges to each of us to weather. I think if you're like me, you're starting to see a little bit of light at the end of the tunnel as we start repositioning how we come out of the pandemic and how we try to advance discussions across the country and in Chicago in ways that are conducive for all of us. So one other, I think, notion I've been thinking a lot about is some of the incredible changes that have been wrought in the last year, and some of the things I think the new environments will allow us to do to really shift the baseline in what we're doing with this industry, not just in Chicago, but across the country. So many of the things that were in flight in 2019 around digital health, alternative payment models, health equity. These are all things that were moving and advancing, but they were going at the pace of our industry. And circumstances and now the policy environment may force them to go a little quicker. So my lens here will be both as a summary of the report and also key things we're thinking about or hoping to see as we move forward. And I want to bucket that into just 6 categories quickly before we bring others in. The first is just the policy landscape. I'm going to dispense with federal policy, but if there are questions around that, I'm happy to take those as well as I'm sure my colleagues are. But here in the state of Illinois, we didn't have as much disruption per se as we saw across the rest of the country. However, there are 2 really important things we are thinking about. The first is the budgetary impact Springfield is navigating as a result of the economic contraction we experienced last year and continue to experience now as we move into the new year. That's everything from state budget, which is anticipated to show a $6 billion deficit over the next couple of years, to the challenges placed on our provider systems, independent physician practices, and the exacerbation of poverty or health and social inequities that we saw prior to the period. Springfield is going to have hands full. This already comes, of course, on the backdrop of pre-existing and immense budgetary challenges that are now going to be pushed even further. If that wasn't enough in the Illinois context, We are also now midway into a 4-year term for a governor who has whose administrative priorities were shadowed or overshadowed by the period over the last year or two. So there's still a lot that has to happen in policy as we advance out of this and then move right into an electoral cycle in our state against the backdrop of pretty significant social and political fissures. So expect, we think, a lot of policy activity as we try to navigate a $6 billion hole to fill, an election cycle, and an exit period out of the pandemic period. Item 2 would be the COVID-19 subject itself. We've talked at length within the council and through programming about COVID-19, and so I'll dispense with the historical overview and all the things that I think we've come to believe and know about the period. I will just say a couple of things about this, however. The first would be germane to the vaccine rollout. We have a little bit of two things going on at the same time. On the one hand, we know we do not have enough vaccines in the state to accommodate the general demand we would see. That's causing a lot of line jumping and other forms of less savory activity in trying to get vaccinated. At the same time, for individuals with particular jobs or in particular demographies, we're not seeing the level of demand for vaccines, a general level of distrust. We know that distrust is not germane to Chicago, but it is highly acute in very specific communities where our friends on the front lines are really trying to make a case for the importance of getting vaccinated and trying to really foster, catalyze this herd mentality notion vis-a-vis vaccinations. While we're doing that, we're also balancing the need for continued public safety. As many of you know, vaccination does not just mean we are back to where we were. Virus can still be carried, it can still be transmitted. So we're going to have this interesting balance as we try to navigate a return to normalcy while we're still trying to scale up vaccinations so we can preserve and mitigate the amount of disease spread and or mortality that can come from that or as a result of that. This leaves the city and all of us wrangling with difficult choices to make. When do we reopen our office, return to work? What does that look like? What happens if the variant that has been traced to African countries or the United Kingdom becomes more transmissible and more resistant to the different vaccines we're seeing? There's a lot we still don't know about the period ahead. If you joined us late last year for Dr. Ashish Shah, who's a brilliant guy, he shared with us this notion of we are entering an age of pandemics, and that has really stuck with me because historically we only see something like this every few decades, every century. But if there is a notion that we've got to kind of be on constant war footing, what do we have to do to get better at anticipating and preventing the 500,000 deaths Stephen spoke to earlier, or making sure we are able to still have a semi-functional economy while navigating the strain of that. So there's a lot on the city right now, on the state. There's a lot on each of us to make sure we are engaging and behaving in responsible ways and ways that are being additive and accretive, not dilutive. And digressive. Third area I'd like to cover is mergers and acquisitions, and something we're not talking as much about in the COVID environment, but something that's important nevertheless. We've thought a lot about this over the last few iterations of this paper because there has been a lot of blockbuster activity for our city and for our state between payers and providers. In the paper, we catalog some of that, but also really try to make the point that we're not anticipating to see a lot of this. I think that may be a positive thing for us. On the payer side, particularly for Medicaid managed care organizations, I think we're starting to see a settling of the dust of a series of transactions that have occurred recently that really kind of leave us typecast over the next 2 to 4 years with respect to who we'll see participating in the market and with what logo they represent those interests from. That could serve to be a positive thing in the payer community if we're focusing less on M&A, integration, normalization vis-a-vis these acquisitions. It ought to give us the opportunity to start thinking more strategically about payment alignment and reform, patient engagement, the implementing the use of digital tools, and how to anticipate, of course, another pandemic should one occur, or the elongated period we might see with COVID-19. On the provider side, we know there are some local providers with big ambitions. We also know that navigating hospital mergers has become more difficult, particularly in Chicago in recent years. And if you're paying any attention to the Federal Trade Commission and some of the signals that they've started to put out, it will become more difficult still in the years to come as we try to strike this balance between what a healthy, competitive market looks like in a market that has too much market power, concentrated power in one particular sector. We expect, as a result of these two things and a normalization of that M&A period, that it will open the doors and create a platform for even greater collaborations. That is an exciting thing, again, given some of the other structural changes that we see now and anticipate we may see in the environment. Fourth area would be on innovation. I'll go through this one a little more quickly, and we'll look to our friend Chris Booker to share some of his thoughts, but obviously we are still living through a digital deluge in healthcare, venture capital, private equity, spinning out more and more point solutions. I believe we are on the front end of beginning to see the next phase of this period, which is exemplified best probably by some of the things we've seen from the homegrown company of Livongo, who, as you all know, had an IPO recently. Was purchased by Teladoc. They in turn purchased MyStrength, which is a cognitive behavioral therapy online platform. And we're starting to see this vertical stack or integration of chronic disease management platforms. We're starting to see providers and payers, particularly through this period, really challenge solutions companies to think less in the context of point solutions and more in the context of fully integrated solutions as enablers of workflows and functions within the ecosystem. One of the things that I think is a silver lining about the last few months is we took years and years of regulatory policy and market work to implement things like telemedicine, community referral platforms, and we did it in days or weeks, which really shows we can do this stuff when we want. So long as we have the fortitude and the will to get it done. Fifth category I want to hit on is on value-based care. Continue to call out, as we have in every report, we are still terrible at this in Chicago. And this would be the opportunity for us to begin rethinking how we need to create better alignment in the financials between payers, providers, physicians, patients, and bring in other parts of the system. There are things we are seeing continue to emerge, patterned after things like the Medical Home Network initiative with the county health plan. Some of the work Oak Street has been really progressive in leading here in Chicago and across the country. We need to do more than we are doing. And if there is a veritable normalization of an M&A period, conjoined with some of these other things we talk about in the paper, there is an opportunity. We should let that lapse. The final thing I want to hit on is saved for last, not because it's at the bottom of the list, but because it's maybe the one I want to be most emphatic about emphasizing, and it's how I'd like to segue into our panel discussion, and it's around health equity. If you've attended any of our programs over the last couple of years, you know this is a lens for us. And that we talk about the subject a lot, particularly in our city. And as Stephen and Meghan both indicated, and as we all know, 2020 really shone a bright light on these health disparities that we see amongst and between communities. This is no longer some kind of cerebral, ethereal discussion we can afford to have in this city. We saw this socially blow open over the last few months, over the last year, and we are out of space to be able to keep kicking the can down the road as we think about the safety net and about transformation. In a couple of years, we have seen Westlake, Metro South, and Mercy announce the closure of their facilities. We are dealing with massive unfunded operational liabilities in the safety net community. All the while there's safety net politicking going on, and we continue to see poor outcomes, poor linkages, and mistrust in these communities. This is critical. This is not something that should just be left to community leaders, just left to hospital leaders. If you have an interest in Chicago, you live in Chicago, it impacts you. This is a symbiotic ecosystem, and every single one of us should look to live in an environment where the resources we expend should be used as efficiently as possible, and their impact should be going to create the kinds of access to resources and services that we all would want access to, that we all believe any dignified human being would want to have access to. And we have that capacity and capability in our grasp today. So as the state thinks about its $150 million annual outlay in transformation funding, as we think about Medicaid reforms, as we think about MCOs, beginning to really focus on the core strategic work we need to do, innovation, budget pressures, everything comes together in a way that gives us an opportunity to be more deliberate and thoughtful about health equity. We got to stop talking about it, and we got to stop playing politics with it, and we got to advance it. So with those 6 areas, let me go ahead and invite my colleagues to turn on their screen. I will do a quick introduction for them because like you, I am very interested to get their perspectives on a range of things. I'll first introduce Chris Booker, who is a partner with Frist Cressey Ventures. If you're wondering why a Nashville guy who's enjoying 50-degree weather is in a Chicago meeting, it's because Chris works with a guy named Bill Frist, who was a former senator and who's very involved in the Nashville Healthcare Council. They've been a corollary for the work we've been doing. They've been strong supporters of our work. And so we're pleased to have Chris's perspective on the innovation investment side of things. Dr. Ali Khan, who's the Executive Medical Director for Oak Street Health. You'd have to be living under a rock to not know who Oak Street is at this point, and given the tremendous growth they've had. Also wonderful partners and collaborators with the Healthcare Council. And Dr. Khan, it's wonderful to have you join us. Thank you. Dr. Fernando De Mayo, who is a health equity research and data use executive for the Center for Health Equity at the American Medical Association. The AMA, of course, just a little trade association downtown, who does a lot of work nationally, but has taken a tremendous focus on health equity in recent months, and it's been exciting to see. So Fernando, thank you both for your participation and contributions with the paper and for joining us today. And last but not least, our friend Dr. Cheryl Whitaker, who's the president of the Institute of Medicine of Chicago and has like 5 other titles that I can never keep up with because she's just a rock star. So Cheryl, I have probably done you total disservice in the introduction, but has definitely been a leader on all things safety net and Medicaid in our state for years. So we would do a round of applause, but you know, we're not where we would love to be. So Cheryl, let me jump just first to you. And thinking just a little bit about some of the things I said and this environment, I am just so interested to get your take. What have you been thinking? What have you been feeling? And do you share any of the optimism that like maybe this is a unique moment in time? Or are you kind of a cynic and thinking like, oh my gosh, we have such a long way to go, I don't even know where to start?
Well, first, thanks for being here, and it's great to be on the panel with this great set of professionals you guys have put together. Uh, so David, I enjoyed your walk into this part of the panel. I actually am optimistic as well. Now we've got like a lot to do. Okay, so that's why I think we need like a 10-year plan that we can all collectively march to with some goals and metrics as a part of that. I like that health equity is something now that people are indeed saying, and that it starts with people being comfortable just saying the words, but then that we are hopefully as a collective kind of marching to getting to that point. Um, I'm going to talk about Medicaid. I spent a lot of time in that space. Uh, as an example, Medicaid does over 50% of the births here in Illinois. So they are really a critical, important player when it comes to financing healthcare, really for about 25% of Illinoisans, okay? So a very important factor there. They have recently submitted to the feds a new proposal, updated, informed by an equity lens, a new quality proposal to the feds. And so that's, I think they're just literally submitting it. They presented on Friday to the State Medicaid Advisory Committee, but it does sort of attempt to break away from what has been traditionally thought of as, say, quality, and really begin to say, wow, from an equity perspective, what does that mean? And if we could get there, how we measure it. So I'm excited about, so they're a market mover, if you will, if they're funding 50% of births. Here's the second thing. I'm not excited about this, but I do feel like it's now something that we're talking about. We know that Black women are 6 times more likely to have experienced maternal death. And we know that we have a huge gap issue here in Illinois. I think it's finally time for us to admit that if we take, for example, the South Side of Chicago as an important microcosm, that the free market now has failed us there. So labor and delivery units are shutting down, right? You listed a number of entities that had closed. Along with that closure, L&D likely closed with. So over the last 5 years, the South Side has had like 7 L&Ds close. And so the access to things like a perinatologist or maternal fetal for complex care, the right type of imaging ultrasound, those things are missing in that community. So while we don't have a solution, David, I think the fact that we're at least now talking about it out loud is very important. And perhaps some of the transformation that is likely to occur in the next decade can include solutioning where free market fails, right? When the market doesn't work, then our question now is, what do we do?
Cheryl, thank you so much. By the way, we did get our very first question. It's from a guy who also has the last name Whitaker. You might know him, first name Eric. He said he tuned in. He didn't even know you were a panelist, Cheryl. And then he said, great choice. Cheryl, let me ask you just one other follow-up question really quickly. You mentioned a 10-year plan. God, do I agree with that. Who puts that together? And if I'm asking myself as a community member, I'm any one of the other 100 some odd plus people in this meeting, and I'm thinking that's a great idea. I would love to be involved in that. Like, how do we really do this in a collaborative way? Like, Cheryl, you know this. I am always astonished. Safety net politics in our city is crazy because we all are ostensibly, we're all saying we want to do the same thing. But we make it really hard to come together to do the 10-year plan. Like, how do we get to that place?
Well, first, I think this kind of convening is really important. And one, I think Healthcare and Family Services, now they issued an RFP, if you will, or an RFI for healthcare transformation. So they're looking for great ideas. Number one, they're as a huge payer. I think there are other payers that would lean in as well if presented, something that really got towards solutioning. But then, David, the 10-year plan might be the Institute of Medicine of Chicago, HC3, and others saying, can we bring together the Chicago Department of Public Health, the Cook County Department of Public Health, and the state sort of Medicaid Council? Because guess what? I don't think any of them talk to each other. So we're dispensing a ton of resources. I believe like the city of Chicago has a 20 by 25 plan, some plan they just released, right? So did they talk to Medicaid, who's the largest payer, if you will, in the state? So I think we might need new sort of fresh groups with fresh ideas who really want to say, hey, how do we get to action, even to bring our state, county, and city entities together to actually collaborate? Because I think if you align them, that's a start. And then a lot of innovation can flow out of having a solid sort of public policy approach that's agreed upon. I don't have the answer though, and I don't want to take up the entire time talking about answering my part of this question. But I do think it may be time for people like the Institute of Medicine of Chicago, for HC3, to sort of ask for a 10-year plan that is aligned across all the large entities in the state, entities large and small, because a lot of them have plans. Someone needs to take all their plans, sort of line them up and put them all together and say, this is our collective Illinois plan.
Cheryl, we accept your offer. And I agree 100%. I think the other thing, and I know you agree with this, is that I think part of the reason we failed at this historically is we've also done it at the expense of, or without the inclusion of, the communities we're actually planning for. And so that can't be token participation or inclusion or involvement. That has to be empathic, thoughtful, deliberate inclusion and collaboration. So Cheryl, more back to you in a bit. Fernando, let's keep with the equity piece as we start to transition back into some of the other market and policy areas. Talk just a little bit about the work you're doing at the AMA, as you heard Cheryl share some of her thoughts about the city. What are some of the things you're seeing and thinking, particularly as we come into to this new year?
Sure. Thanks, David. And congratulations to you and the team for this great report. It's an honor to be part of it and to be part of this conversation. And I think the report really plays a really vital role, right, of helping us to take stock of current activities and spurring ideas about how to move forward. And in many ways, I wish we had been doing this a long time ago. A couple of years ago, a group of us edited a book on health equity work in Chicago, going back to 1901, which was the first map of excess child mortality that we found by a community. This was before we had the communities officially named in the 1920s. Even before they were named, we knew population health patterns were deeply unjust and inequitable. And I would have loved to have seen these kind of snapshots, these kind of reports, these kind of inventories in previous decades. Because I think as we try to take stock and look to the future, we also need to look back, right? The 10-year plan moving forward has to be grounded in the 100-year history of mostly failed efforts at overcoming segregation and discrimination in our medical institutions. You know, all of this gets me thinking. In the 1950s, there was a pamphlet put out by the medical Committee to End Discrimination in Chicago medical institutions called "What Color Are Your Germs?" using birth records to document health inequities. In the 1960s, Dr. Quentin Young, who's a hero to many people in this call, on behalf of the Medical Committee for Human Rights, concluded that our nation has broken a compact to achieve human equality. Again, using health data as a marker of that injustice. And all of that is our lived reality today, right? We have an 8.8-year gap in life expectancy between non-Hispanic whites and non-Hispanic Blacks in the city of Chicago. Most of that is driven by premature mortality from chronic disease, right? The stuff that our healthcare system is capable of addressing. Between 2012 and 2017, life expectancy in our city fell for everyone except for non-Hispanic whites. That should be a huge alarm, raising alarm and alarm for all of us. That business as usual doesn't work, right? The data are very clear in that. And of course, COVID is adding a hugely inequitable burden on top of this unjust landscape. So I think as we try to take stock of what we're doing now, what we do in the future, we also need to be grounded in the history and our data. And both of those, I think, serve as guiding posts and causes for alarm. We know, of course, that healthcare isn't necessarily the solution to all of this, right? That health inequities are produced that reflect inequities in all areas of life: housing, education, employment, transportation, the criminal justice system. So really tackling this effort really calls on us to have a sense of humility, right? Recognizing the failed efforts of the past and the fact that physicians, healthcare systems by themselves cannot address the deep patterns of inequity that we see in our city. But I'm grateful to be working with all of you in an effort to overcome that in the future.
Fernando, thank you so much. The more I want to dig into in a few minutes. I think this is those of you that have participated in programs with us recently know that this has become something we have anchored really closely to. And the reason for that is there's the moral reason, but there is also a core economic imperative for us in this city to get better at this. Our system cannot function if our health, not healthcare, if our health is collectively not at where it needs to be. And I think Fernando, as you said, or intimated, it's taken us a long time, it's taken us generations to find ourselves to this place. It's going to take us generations to get out of that place, or out of this place. But I think a lot about this notion of, I've said it before, the best time to plant a tree was 20 years ago. The next best time is today. There is that opportunity today to really craft that approach. So more on that in a minute. Ali, I want to turn to you. Let's pivot for a moment. I know you guys are really involved right now in helping with the vaccine rollout within your clinics. I know that your physician colleagues have been introduced to a very different way of working and interacting. Maybe talk just a little bit about how you've seen the world shift a little bit at Oak Street for your clinical colleagues on the ground, and then what you're really doing to position for driving vaccines, driving health, and thinking about your fit in this environment in 2021 and beyond.
David, thanks so much. It's a great question. Kudos to HC3 and the council for putting this event together. It's been fantastic so far. I think honestly, one thing that we said a lot of during the pandemic, right, during the peak of the pandemic back in March, April, May, was that this has never been a better argument for value-based care, right, on some level. I think what we saw in terms of the exposure of the constraints of fee-for-service reimbursement on the overall medical industrial complex is pretty palpable, right? Lots of hard decisions made by many health systems, a lot of different actors, lots of practices closing, lots of things going on. For us at Oak Street, beyond pivoting to telehealth, being in a fully capitated environment has really enabled us, and I think peers around the country, to say, how do we just, mine the frontiers of creativity, right? Let's take our drivers that normally are focusing on last mile issues of transportation, taking patients to and from clinics, and flip them instead to keep helping people stay safe at home, particularly on the south side and the west side, by delivering, groceries, toilet paper, the prized toilet paper, and dry goods on a weekly basis to keep 6,000, 7,000 seniors, highly vulnerable seniors, safe at home, right? How do you bridge sort of gaps in broadband access and internet inequity by delivering tablets that are Wi-Fi enabled to make sure your patients can be seen, right? And deliver flip to mobile team models when you've got the appropriate PPE. So for us, I think, this has been obviously a time of great creativity and innovation, but it's been unfortunate to watch that, as we know that many of our brothers and sisters at centers and health systems across the region, across the country, obviously are really suffering. I think it's probably no surprise, right, that occurs against this backdrop of this past year, where we really see the progeny, right, of Obama policy changes growing up, right? Groups like Accolade, groups like ourselves, Oscar, Signify, Clover, all coming in and really getting to the place of an IPO or a SPAC or whatever, really says there's real legs here, right? In terms of thinking about how different models of care and financing can push towards meaningful impact on social communities. I guess the question I think that I keep coming back to from our health system peers is, are we going to all pivot towards these kinds of new ways, or are systems going to retrench in terms of doing what they've always done before, right? And I think to the point you raised earlier, right, we have to stop talking about health equity. We have had two dual pandemics, right? Both COVID-19 and structural racism. that have laid that truth, that we've known for a long time subtly out for everyone to see. Equity has to be front and center on the agenda. And I think from the work of groups like the Vaccine Corps Partnership here in Chicago, the Racial Equity Rapid Response Team, it's very clear that like public-private partnerships can work when they're well-structured, deliberate, and very nimble. Because in a lot of ways, we have to figure out how to fill the gaps like left by decades of underfunding public health. For us at Oak Street, this has been a lot of fun and a lot of stress the past month and a half, because we're currently delivering 1 out of every 10 vaccines in the city of Chicago, right? In terms of getting those into arms every day. That is, we're punching well above our weight, right? Relative to a lot of the historical health systems here. And so I think how we think about what is the potential for a Walgreens and Village MD to do the same, right? What's the potential for us and Walmart to do the same, or other innovative partnerships that are happening? How can we leverage different actors than what we've historically leveraged? I think to Dr. Whitaker's point, towards centering around the common good becomes a really fundamental point that we all have to ask ourselves. And the last point I'll leave with is this. I think what we've seen most of all, especially in the last few weeks, which is not really 2020, but is 2021, it has made very clear some of the lessons of 2020. Institutional affiliation is really, honestly, the new undiscovered health disparity, right? When we think about this from Southside pharmacies closing in the wake of protest action and during the summer, right? We think about vaccine distribution and how people are just trying to fight this Hunger Games scenario, trying to figure out how to get a vaccine. Tens, if not hundreds of thousands of 1A healthcare workers who don't happen to belong to Northwestern or UChicago or even us, looking for a place to somehow get vaccinated. They're ready, they're often minority, but they just don't know how to navigate this, right? Even the closure of Mercy Hospital, right? Like monoclonal antibody access. I think we have a lot of work to do, to Dr. Whitaker's point, right? And so I think the question really becomes, how do we actually partner meaningfully, right? With the right stakeholders, not necessarily just the historical ones. And I think what are the accountability structures therein to help all of us, our providers at Oak Street, provide clinicians across the community-based organizations, large health systems, plans, to Dr. Whitaker's point, to really say, how do we actually get there? And get there not in 10 years, but in 1 year is going to be the real question I think all of us are reckoning with right now.
I want to just repeat what you said, Ollie, and then one other quick follow-up that'll be a nice segue to Chris. Now I'm going to mess up the quote, but I'm going to get the general spirit of it right. We have to be partnering with the right stakeholders, not just the historical ones. And this notion of following the same playbook and trying to solve these challenges that those playbooks have not solved, have not addressed. I think that's critical. One of the reasons been excited to have you guys as a member colleague and also have you on this panel is you really are emblematic of that new cut. You mentioned Village MD, another big Chicago homegrown business. Walmart, 2 new clinics, one in Chatham, one in Austin, 7,000 square feet, access to specialists and mental health professionals and well-being resources. We are seeing the ground start to shift in really big ways about our traditional definition of a provider, of the kinds of things a hospital could, should, ought to do versus a community provider. We know we have an incredible FQHC community in the city and state. Ali, I guess just maybe from a disruption perspective, like where do you see this going? Do you see Walmart being kind of another one of several fads we've seen over the last few years, like the Haven project, and it'll just kind of slowly disappear? Or do we think these disruptions are going to really put pressure on our traditional payer provider roles and definitions? Does that start to move our incumbents in a way that recast resources?
Honestly, I think a lot of this is going to be dictated in the next 6 to 12 months, David. And then when I say that is that if Walmart can securely deliver the vaccine to thousands of Chicagoans when, any number of FQHC networks or, small hospitals struggling to even get vaccine can't, right? You've got a huge reason to move over, right? People are going to vote with their feet right now. And I think what we're seeing at Oak Street is that the outreach that we're doing, for example, to, unaffiliated 1B seniors, whether they're our patients or whether in other communities like in Englewood, in Austin, in, East Garfield Park where I practice, in Rogers Park, that, our patients are not necessarily like eager to maintain the status quo either. They just don't necessarily know how to navigate it, right? And so if groups like Walmart come in, when Walgreens comes in, established players with real brand identity, showing potentially a different way forward, a more accessible way forward, a slightly more joyful way forward, it's pretty clear, I think, from our experience and from others in the value-based care delivery space, is that can be quite attractive, right? And so how we all come together to say, maybe those shifts are ones that are desirable, but maybe those shifts are ones where, in some cases, we don't want somebody shifting out of Chicago for primary care because all their transplant stuff happens there, right? So how are we working together across institutions to then say, let's make sure we're keeping people in the medical homes that they're at, but also enabling enough competition that allows, Walmart to predicate its 10 years of work in healthcare delivery, and that's only really now appearing, to say like, it's going to push all of us to be better.
Yeah.
I realize it's a little bit of a hedge, but I think their potential is immense. We're lucky to be partnering with them in Texas, right? As part of that strategy. But I think it's also about how we recognize the moment that we're in, and all of us across Chicago then say, how do we look within ourselves to really recommit to that effective kind of partnership so that we are continuing to stabilize the system as opposed to just waiting for that more disruption?
I'm going to take the moderator's prerogative and insert an editorial opinion. I agree a lot with what you said. Something Cheryl said at the onset, I think is really important. And Cheryl, I don't mean to put words in your mouth, so I hope I'm getting the idea of this right. But this notion that the fundamental market mechanics have failed us in these communities. And we've generally tried to solve that, I think, through policy and through public programs, but we've also failed at that. And so there's this really, I have this kind of moral tension within myself, because on the one hand, I think to myself, well, wonderful if big capitalized entities can disrupt, especially the industrial complex status quo, but also fix other gaps. On the other hand, I kind of think to myself, oh my God, we have this amazing infrastructure, this amazing base, and we can't disintermediate that, because in some cases, these are the entities, the physicians, the brands that patients know and they trust, but we have done a disservice to them over several years in the way in which we have paid for and structured this system. I think one of the things I'm thinking about is, how do we create the right balance with alternative models for delivery and providing care and the capital that can bring in, while also creating and fostering a better economic climate on which our core infrastructure can operate. I know that sounds Cheryl and I are going to figure that out in the 10-year plan, y'all. So just come check back with us in a few months. That's obviously a big thing. Chris, let's come to you because I want to kind of round this out. I asked Ali to talk a little bit about disruptors. You guys are obviously very steeped in Chicago and other parts of the country and making investments. I made the Livongo Teladoc My Strength corollary. What do we think is going to happen? Are we going to see another 20,000 apps come out, or are we starting to see this now get to ground and find ways to complement the core system?
Yeah, it's a great question around innovation. The healthcare patient kind of went to bed in 2019 and woke up in 2030 as kind of a healthcare consumer. Like, I was very anti-consumer in healthcare. And now, because of COVID, we've really accelerated a lot of innovation. Look, 2020 was hard on my family, hard on a lot of families out there, and a lot of inequity, a lot of disparity, a lot of issues. The one thing it did do on a positive note is accelerated a lot of innovation, particularly being driven by the consumer, the healthcare consumer. Now, Cheryl and I will have some great debates on the free market. I'm a free market guy and more of an economist. I love Medicare and Medicaid. We're seeing a lot of innovation in that area. Half of healthcare is being paid for by government entity. So we've taken away some of the economic incentives to change consumer behavior. But one of the other incentives that we have is convenience, your lifestyle, your family, your health, everything else we still have there. And now COVID has allowed for that convenience to come full circle. to add to Cheryl's point, you know, it's funny. We've been looking at like labor and delivery, which the only experience I have as a having 3 children and watching my wife do all the work. But on the labor and delivery side, you know, there's a lot of them being shut down. And I'll just add to this. This is an innovation that we're seeing. Well, the first president to be born in a hospital was actually Jimmy Carter, the peanut farmer who's still alive today. We've taken, and there's been a lot of forces and brought labor and delivery back into a hospital. Well, there's been a lot of research that says, hey, why do we need labor and delivery in the hospital? Why can't it be done in another setting that's a lower cost and you actually get better outcomes? So I think there is some innovation that's happening throughout the market because of COVID. It's been accelerated. And I think one of the biggest accelerants of some of this innovation is the consumer is now demanding it.
I want to ask just one other quick question on that. And I just checked the time, and just emblematic how much time can fly when you are having fun. Chris, let me ask a follow-up to you. And then I've got one other quick question I want to cover that felt really important to me. Chris, I share the optimism on the consumer side. I'm also one of those people like you who goes to conferences, and every year we declare this is the year of the consumer. And then it turns out like it's not the year of the consumer. That's actually like 2 years from now. I do think COVID has changed the social compacts. And so whatever baseline time frame we were on has moved. Here's the question. All the rules we're seeing in DC around interoperability, the kinds of things Fred Rockman and the team do at Alliance Chicago, and the FQHC community, the transparency rules we're going to see in 2022. Like, how does this all come together to really, like, where do we really believe the consumer will be more active? Because there's a consumer desire and willingness to do it. And then there's the American medical industrial complex that makes it hell for a patient or consumer to actually do it.
Yeah, look, let's get the rules in place, right? If we can get the rules in place and not change the rules, then we can create innovation. You know, whether it's we want to go capitated, but then we're going to make that not as advantageous. I think as you look at some of the areas where we get the rules in place, you know, price transparency, good, bad, or ugly. I know everybody has their opinion around price transparency, but that's one area that I think the consumer can start engaging in their own healthcare when there is true price transparency. I had an MRI and it cost me 4 times as much as it did 6 months ago because it was bought by an academic center, and this happened this summer. Those pricing transparency and pricing decisions, I think, could be one area. But I think the other issue is as we're looking to innovate and change rules, whether it's Medicare or Medicaid, several of you talked about this. I was at a large conference. We're all talking about innovation in Medicaid. And there were 7 of us. And I looked around the room and I said, how many of you have ever been on Medicaid? I grew up in Mississippi in a rural area. So I had families on Medicaid, know a decent bit about it. And nobody raised their hand. It was, 7 people that have probably not interacted with somebody from Medicaid in a very long time. And I think the people in these populations, whether we're trying to fix rural, whether we're trying to fix inner city, whether we're trying to fix the deep South, which is very anti-government and is not taking the vaccine, which is a horrible problem in Louisiana, Mississippi, and Alabama. How do we integrate their voices intently as we create these rules so we can actually drive change?
Yeah, Chris, thank you. Cheryl, let me pitch to you real quick. We're in rapid fire mode. I know I'm doing that right as the dog is making his or her debut for you. Cheryl, you've spent so much time in the payer world and in the provider/delivery world. So one, just anything else you've heard in the last couple of minutes you want to comment on, and 2, do you think I'm right about the M&A thing? Do you think things are going to slow down a little bit? And if so, can we finally get to work on real APMs, or do we still have more dust to settle?
Well, I'll take my minute. I want to one, just say to Chris, I 100% believe in the free market. I actually 100% agree in alternative models to L&D. But the question is, when can innovation keep up with the level of need? And I think we have to be kind of intentional in thinking about, okay, if I got a whole swath of the city that doesn't have access to L&D, a maternal fetal medicine specialist, and the right type of imaging, what is that, right? So in that case, more innovation is actually needed. It's just a question of, can you get that L&D center up? I think you have a lot of business on the south side of Chicago, but you do so also need the layers of care, which is what you're also missing. So that's a little bit more free market, academia, et cetera. But here's another thing I want to just say. I'm gonna give you guys an example of with data. So on the Next Level Health side, I started Next Level Health from scratch, poured out my retirement into trying to build a model that could go after disparities in a unique way, really using the payer lens. Here's some of the data that we do. One big lesson. I just want to share this, and I'm gonna leave it. I live on 60649. It was a high, propensity for COVID vaccine, COVID infections early on. But anyways, you drive around to the different neighborhoods, Chatham, et cetera, all the different neighborhoods. Over the last decade, guys, the number of entities, I'll just name the companies, are publicly traded. They know they'll be mentioned from time to time. DaVita and Fresenius, they have sites. You know what they do? They mine data, the same data we have access to. So why can't we take a look at the creatinine, the percent increase, knowing that it's going to hit a point on the curve, and that's when you're heading to dialysis or transplant if you're lucky enough to not be discriminated against to get access to that. But guys, the free market, DaVita and Fresenius, they see the same increase in chronic kidney disease that we do. I challenge us to see that increase, and how can we stop it instead of just benefiting from it? Can we figure out a way to prevent all this morbidity and mortality with the data that we all have? So I like to say, wow, data is super available. Can you take all that, to your point, take all these different stakeholders and line this up around commonly what would be better for the society, not just industry? So the two sort of need to meet. And I think that's probably our biggest challenge.
Based on a bunch of chats and Q&As and messenger pigeons I'm receiving, this notion of what is the role of free market, what is the role of government and Medicaid, I think this is something we ought to probably dig into. We obviously won't do that in 2 minutes, but I think as a separate program, because I have a lot of things to say on this, and I'd love to bring back the group and kind of dig into that a little more. Knowing we're out of time, I asked everybody 2 questions with the exception of our friend Dr. DeMaio. So Fernando, let me just close with you, since we do want to try and land the plane on time here. I would maybe just ask, I asked Cheryl, like, optimistic, cynical. She was in the optimist camp. Where are you, and what would you say is the one biggest thing, like if you knew a bunch of people were going to be listening to this now or will listen to it later, what is the one thing we should all be thinking about as we go through 2021 and we're trying to play our role, whatever that is, in equity?
Yeah, no, that's a great question. And I guess I want to come back to a comment that Stephen made in the very early part of the conversation, that now we're at a time where health inequities, where no one can deny their existence. But we do want to acknowledge that there's huge debates about where health inequities derive from, right? There's still lots of people and organizations who look at biological models, behavioral models, genetic models, relatively fewer institutions and systems that recognize the structural drivers of these problems, right? The systems of oppression, the systems of power that disadvantage some and advantage others. So how do we recognize that diversity of thought and really transform the healthcare system, right? So it actually espouses the anti-racist principles that many have now committed to. So I'm optimistic. The data are warning, there's a red alarm bells ringing everywhere, but I think there's enough momentum to recognize this as a question of justice, right? That can and must be overcome.
Fernando, thank you so much. More to come on all this stuff. We've got a really ambitious set of things we want to accomplish this year, both in convening and the work that we do. Thanks to all 4 of you for your time and joining us this afternoon. And to all of you that have tuned in now or are watching this on the website. I know we're at time, so Meghan, I'll turn it to you to play us out.
Yes, wow, we're definitely probably need to book a part 2 because there's a lot more to unpack. And so all of you are welcome back to HC3 events and will be on our speed dial. So thank you all so much for your contributions. Thank you, David, for leading this discussion. As a reminder, there will be a recording and recap available on our website in the next few days. Additionally, I encourage you to visit our website. There are some new events up that will be promoted starting this week for early March, so you can learn more about that. But thank you all for your time. Be safe, mask up, and stay warm, Chicago. I hope you all have a great afternoon.
Thank you.